Between 2 a.m. and 6 a.m., something measurable happens inside every cardiovascular system over 60 that has nothing to do with diet or medication, and everything to do with which direction the body is facing on the mattress. Research indicates specific sleep positions may reduce cerebral blood flow enough to create biological clotting conditions, quietly, without symptoms, while the body is unconscious and unable to respond. Every hour of sleep is compressing something or opening something inside your arteries. In adults over 60, nitric oxide, the molecule blood vessels use to stay relaxed, drops during sleep, and body position determines whether vessels can compensate or cannot. Here is what no one has said plainly. You have spent decades watching what you eat before bed and almost no time considering what your heart is doing during it. What if one free change tonight made those 8 hours work for your cardiovascular system instead of against it? My name is Dr. Daniel. I am a cardiologist and sleep medicine specialist with 23 years focused on how sleep positions influence stroke outcomes in adults over 60. In the next few minutes, I will show you exactly which positions are silently loading stroke risk and which single change research suggests may support healthier blood flow starting tonight. Sleep is not the safe harbor your cardiovascular system has been promised. Most adults over 60 assume that the moment their head touches the pillow, the heart finally gets to rest. The blood pressure drops, the body goes still, and 8 hours of recovery begin. That assumption feels reasonable. It is also, according to 2 decades of cardiovascular sleep research, incomplete in ways that carry real consequences, because what happens inside your vessels while you sleep is not passive recovery. It is active biological negotiation, and after 60, that negotiation becomes measurably more fragile with every passing year. Old paint left in a can overnight thickens at the bottom, not because anything was added to it, because movement stopped. Blood behaves by a related principle. During the overnight hours, as the body stays still and circulation slows, blood viscosity rises, clotting factors increase, and the natural turbulence that keeps platelets moving freely through waking hours disappears entirely. The vessels that were handling that chemistry during the day are now handling a thicker, stickier version of it for 8 uninterrupted hours while you sleep. The molecule responsible for keeping blood vessel walls relaxed and resistant to clot adhesion is nitric oxide. It is produced by the endothelial cells lining every artery and vein in the body. In adults over 60, age-related circadian changes slow endothelial cell activity during sleep, and nitric oxide production drops precisely during the hours when blood is already at its thickest and movement is at its lowest. When vessel walls cannot maintain their own relaxation during that window, the biological conditions for clot formation are not just possible, they are structurally in place. The position your body holds while that process runs is not neutral. I have spent 23 years as a cardiologist and sleep medicine specialist watching the connection between what patients do in bed at night and what arrives in the clinic the following morning. The question I stopped asking late in my career and started asking first is, which way were you lying when you fell asleep? What most seniors have never been told is that the sleep positions they have used for decades are not random comfort choices. They carry a measurable cardiovascular cost, and the position that actually works in favor of the heart during those hours is not the one most people would predict. That answer is coming, and it will change what tonight looks like for you. The side most seniors choose because it feels gentler on the chest turns out to be the side that places the greatest positional strain on the heart's own filling efficiency. When the body lies on the right side, the heart shifts slightly within the pericardial sac, the fluid-filled membrane surrounding it, and that shift reduces the efficiency of left ventricular filling. The left ventricle is the chamber responsible for pumping oxygenated blood to the brain and the rest of the body. When it fills less efficiently, it pumps less efficiently, and because the body's blood pressure follows a natural nocturnal dip during sleep, dropping 10 to 20% below daytime levels in healthy adults, that reduction in cardiac output lands during the exact window when cerebral perfusion, the pressure pushing blood into the brain's smallest vessels, is already at its overnight low. In adults over 60 with any degree of arterial stiffness, and research published in European cardiology and cardiac imaging journals suggests that subclinical arterial stiffness is present in the majority of adults in this age group. Studies indicate this combination may contribute to measurably reduced cerebral blood flow velocity during sleep. The brain is receiving less blood under less pressure during hours when the blood itself is thicker and the vessels lining it are less relaxed. That is not a theoretical concern. That is a convergence of biological conditions happening in a body that cannot feel it, respond to it, or interrupt it while you sleep. Worth noting clearly, right-side sleeping is not dangerous for every person in every circumstance. Individual cardiac anatomy, existing diagnoses, and direct physician guidance all apply here. What research suggests is that for adults over 60 with arterial stiffness or reduced cardiac reserve, the positional effect on left ventricular filling deserves a conversation with a cardiologist that most people have never had. If right-side sleeping is your default, that conversation begins tonight. If reduced cardiac output is the first factor, the second involves something even closer to the brain, and it is a connection that standard medical examinations have no mechanism for catching. The carotid arteries are the two vessels running along either side of the neck, and they supply the majority of the brain's blood. They are assessed during routine medical visits through auscultation, a stethoscope on the neck listening for turbulent flow. What that assessment cannot capture is what happens to those arteries over 8 hours of sustained positional pressure, angular restriction, or rotational compression while you sleep. No physician has ever asked you to lie down in your exact sleeping position during an appointment. No examination table replicates a soft mattress, a pillow at a particular height, and the unconscious head rotation that settles into place over the first hour of sleep. When the head is angled too far forward, chin toward chest, the carotid arteries experience anterior compression. When the pillow is too flat, the neck hyperextends, placing stretch tension on the posterior vessels. When the head rotates to one side, as it does for most side sleepers, the vertebral artery on the compressed side faces sustained mechanical pressure for the full duration of sleep. Research in positional stroke medicine and cerebrovascular neurology, including cohort studies examining ischemic events in adults over 65, indicates that prolonged carotid or vertebral artery compression during sleep may be associated with elevated ischemic event risk, particularly in adults with pre-existing atherosclerotic narrowing, where the vessel has less reserve to accommodate even mild external compression. I want to ask you something directly, and I ask every viewer who reaches this point in the video to answer it honestly in the comments below. What sleep position do you use most? And when you wake in the morning, do you notice any unusual heaviness in the head, stiffness through the neck, or a grogginess that takes longer than normal to lift? What you share there has genuinely shaped what questions I investigate next, because those symptoms are showing up in the comments at a frequency that standard clinical practice has not caught up with. Pillow height adjustments are not one-size corrections. Spinal alignment, shoulder width, and existing cervical changes all affect what height is right for a specific individual, and a change that relieves arterial compression for one person may introduce musculoskeletal strain for another. A sleep medicine specialist or physiotherapist can guide that calibration in a way a general practitioner appointment typically does not. What comes next in this conversation is not about position at all. It is about a biological process that begins around 3 a.m. inside every adult over 60, regardless of pillow height, regardless of which side they are on. And it is the reason nighttime stroke risk does not hold steady across the sleeping hours. It spikes. And the timing is precise. Stroke events during sleep do not distribute evenly across the night. Research in cardiovascular chronobiology is consistent on this point. The hours between 3 a.m. and 6 a.m. represent a distinct window of elevated clotting risk, not because something goes wrong, but because several biological processes peak simultaneously and by design. Blood viscosity, the measurable thickness of the blood itself, reaches its overnight high during this window. Platelet aggregation, the tendency of blood cells to clump together as the first stage of clot formation, is also at its peak. And fibrinogen, the protein the body uses to construct clots, follows a circadian pattern that drives its concentration upward through the late sleep hours, as confirmed by research on circadian fibrinogen variation published in cardiovascular and hematology journals. The body is not malfunctioning during this window. It is running a biological process calibrated for a body that will be upright and moving within hours. The problem for adults over 60 is that reduced endothelial nitric oxide production means the vessel walls cannot fully counteract the clotting chemistry through vasodilation the way younger vessels can. Movement during waking hours provides a natural anti-aggregation effect. Deep sleep phases eliminate it completely, and sleep position determines whether the vessels most exposed to this chemistry, the carotid arteries, the cerebral vessels, the inferior vena cava, are held open and unobstructed, or compressed and restricted, during the exact hours when the blood running through them is at its biological thickest while you sleep. Left side positioning addresses this directly. When the body lies on the left side, the inferior vena cava, the body's largest vein, running along the right side of the spinal column and responsible for returning blood from the lower body back to the heart, remains fully uncompressed. Venous return to the right heart is unobstructed. The heart's workload during the low-pressure nocturnal window is reduced. Lymphatic drainage, which peaks during sleep, is supported by gravitational positioning, and the combination of unobstructed venous return and reduced cardiac workload creates conditions where the heart is genuinely recovering, not simply continuing the same strain in a horizontal position. A patient I will call Marcus came to my clinic at 69, not with chest pain or palpitations, but with morning headaches that had followed him for 3 years and a fatigue that no amount of sleep seemed to touch. A full cardiovascular workup had already been completed by his previous physician. Everything had come back within normal limits. No one had asked which direction he faced when he fell asleep. He had slept on his right side for his entire adult life without ever considering it a clinical variable. After a detailed sleep history and a discussion of positional cardiovascular physiology, he made one change: left side sleeping with a pillow positioned behind his back to prevent rolling. 90 days later, he returned with the morning headaches resolved and an ambulatory blood pressure monitor showing measurable reduction in overnight systolic elevation that his previous physician had attributed, without further investigation, to normal aging. The physician had been doing work that nothing in his medical record had named. The cardiovascular cost of how you sleep has been building silently in your body for years, not because the damage is small, but because the mechanism runs in hours when no one is measuring it. Blood viscosity and clotting risk involve multiple overlapping variables: hydration levels, anticoagulant medications, underlying platelet disorders, and cardiovascular comorbidities all influence individual risk. Sleep position is one modifiable factor within that picture, not the complete picture. Any viewer managing anticoagulation therapy or with a history of thrombotic events should discuss positional recommendations directly with their physician. Here is the finding that resets everything else in this conversation. Research in stroke timing chronobiology indicates that in some studies, a disproportionate percentage of nighttime ischemic strokes occur not during the deepest phases of sleep, but in the final 90 minutes before natural waking. When the body is completely still, circulation is at its overnight minimum, and no one else in the house is yet awake to notice that something has changed. The most dangerous moment of the night is the one closest to morning, which brings the next factor into sharp relief. If the blood itself is creating clotting conditions during a specific overnight window, what undiagnosed sleep apnea adds to that window changes the calculation entirely. Approximately 1 in 3 adults over 60 has obstructive sleep apnea. Most of them have never been diagnosed. Many have been told by a partner or family member that they snore, and have filed that information as a minor nuisance rather than a cardiovascular signal. What that framing misses is that obstructive sleep apnea events are not just breathing interruptions. They are oxygen desaturation events, and they carry a specific cardiovascular consequence that, when it lands during the nocturnal clotting window, creates a combination of stressors that sleep cardiology research describes as one of the clearest biological pathways to nocturnal ischemic stroke identified in the literature. During an obstructive apnea event, the airway closes, airflow stops, and oxygen saturation in the blood begins to fall. The sympathetic nervous system detects the drop and responds with a surge. Heart rate spikes, blood pressure elevates, sometimes reaching 30 to 40 millimeters of mercury above the sleeping baseline within seconds. In a younger adult with elastic arteries and full endothelial function, that surge is absorbed. In an adult over 60 with reduced arterial elasticity and lower nitric oxide availability, the same surge hits vessels that are already managing thickened blood, reduced flexibility, and compressed geometry. Research connecting obstructive sleep apnea to atrial fibrillation risk, published in Sleep Cardiology and Cardiac Electrophysiology journals, suggests that repeated overnight sympathetic surges may promote the electrical and structural remodeling that makes arrhythmia and thromboembolic events more likely over time. Positional therapy research consistently shows that lateral sleeping, specifically left lateral positioning, reduces both the frequency and the severity of obstructive apnea events in a significant proportion of patients compared to supine positioning. Sleep apnea is a medical diagnosis. It requires formal evaluation, and the pathway to that evaluation is more accessible than most people realize, with validated screening questionnaires and home sleep tests now widely available through primary care. Morning headaches, sleep that never feels restorative regardless of duration, and breathing pauses observed by a bed partner are the three most consistently reported warning signs. Position change is a meaningful adjunct for apnea management in appropriate patients, but it is not a substitute for diagnosis, and any viewer who recognizes those symptoms should bring them to a physician rather than managing them through positional adjustment alone. If the blood and the breathing are both creating cardiovascular risk during sleep, the fifth factor connects them structurally, and it involves the single anatomical mechanism that determines whether the heart gets any genuine recovery from sleep at all, or whether those 8 hours simply continue the same hemodynamic strain as the hours before. The inferior vena cava is the largest vein in the human body. It collects deoxygenated blood from the legs, the pelvis, and the abdominal organs and returns it to the right side of the heart. It runs along the right side of the lumbar spine. When the body lies flat on its back, the entire weight of the abdominal contents, the liver, the intestines, the stomach, the accumulated mass of the trunk, rests directly on top of it. In adults over 60, where venous return efficiency has already declined due to reduced vessel wall elasticity and decreased muscular pump action in the legs, that compression is not a minor inconvenience. It is a sustained mechanical restriction of the body's primary venous return pathway, held in place for the full duration of sleep while you sleep. The downstream consequence runs in a direct chain. Compressed IVC means reduced venous return to the right heart. Reduced venous return means reduced cardiac output. Reduced cardiac output means reduced cerebral perfusion pressure, the force pushing blood through the brain's smallest capillaries and into the cortical tissue that depends entirely on that continuous supply. In adults with existing cerebrovascular narrowing or subclinical lacunar changes that are often present on imaging in adults over 65 who have never had a clinically apparent stroke, research suggests that even modest reductions in cerebral perfusion pressure during the nocturnal clotting window may be sufficient to tip a compromised vessel toward an ischemic event. Left side positioning removes the abdominal mass from the IVC entirely. Venous return is unobstructed. The right heart fills without restriction, and the cardiac output that reaches the brain during the 3 a.m. to 6 a.m. window does so through vessels that are geometrically open rather than mechanically loaded. Supine positioning has legitimate clinical applications. It is appropriate and sometimes specifically recommended for certain musculoskeletal conditions, post-surgical recovery, and specific respiratory presentations. No positional recommendation overrides individual medical guidance. What this information provides is a framework for a conversation with a physician that most adults over 60 have never initiated, because the question has never been asked. Every one of these 5 factors, the heart's positional compression, the arterial angle at the neck, the overnight clotting window, the apnea desaturation events, the IVC restriction, is modifiable. Tonight, with what is already on the bed, the only thing standing between most viewers and acting on this information is a belief worth examining directly. That belief sounds like this: I have slept this way for 40 years and nothing has gone wrong. It is an honest thought. It deserves an honest clinical response rather than dismissal. Nothing has gone wrong yet. And in cardiovascular medicine, yet is a word that deserves far more scrutiny than it typically receives. Endothelial dysfunction, the gradual loss of the blood vessel lining's ability to regulate its own tone, resist inflammation, and produce nitric oxide, does not produce symptoms. Subclinical atherosclerosis, the slow narrowing of arterial walls by accumulated plaque, builds silently for years before it becomes detectable on a standard clinical examination. Lacunar changes, small areas of reduced perfusion in deep brain tissue, are found on MRI in a substantial proportion of adults over 65 who have never experienced a clinically recognized stroke event. The absence of a visible outcome is not confirmation that the mechanism is not running. It is confirmation that the mechanism has not yet reached the threshold required to produce a symptom you could name. I have reviewed the imaging of patients who described themselves as completely well right up until the morning they were not. The ledger was never clean. It had been accumulating entries for a decade. The entries were just written in a language the body does not translate into symptoms until it has no other option. Moving from right side or supine sleeping toward left lateral positioning does not undo years of cardiovascular accumulation overnight. What it does is stop adding to the ledger tonight and give the vessels a set of conditions during sleep that support rather than strain the biology already working to protect you. What to do before the light goes off is exactly what comes next, and it starts with something already on the bed. Every mechanism described in this video has a practical reversal. None of them require a prescription. None of them require a purchase. And all of them can begin before you fall asleep tonight. The first change is position. Switch to left side sleeping. Research suggests left lateral positioning maintains unobstructed inferior vena cava flow, reduces the heart's overnight workload during the low-pressure nocturnal window, supports cerebral perfusion during the hours of highest clotting risk, and reduces the frequency and severity of positional apnea events in many adults. The body may resist the change initially. Decades of positional habit do not dissolve in one night. That is expected. The cardiovascular benefit of the position begins from the first hour it is held, regardless of familiarity. The second change is one pillow placed between the knees. Left side sleeping without pelvic support causes the upper hip to rotate forward and the torso to follow, which pulls the body toward its back within the first hour of sleep in most people. A pillow between the knees maintains pelvic alignment, holds the lateral position through the full night, and prevents the unconscious return to supine positioning that defeats the purpose of the change entirely. The third change is a slight elevation of the upper body, 15 to 20 degrees, using pillows already on the bed, folded or stacked beneath the upper back and shoulders. Research in sleep cardiology suggests mild head-of-bed elevation may support a reduction in overnight blood pressure elevation and assist gravitational venous return, the same mechanism that makes IVC compression in supine sleeping as consequential as item 5 described. This does not require a wedge pillow or any equipment. It requires 2 pillows and a minute of adjustment before the light goes off. The first of these 3 actions alone, held consistently, shifts the cardiovascular conditions of 8 hours from strain into support. You are not beginning a protocol. You are making one quiet decision tonight that your heart will be working with instead of against while you sleep. 5 things emerged from this conversation that most adults over 60 have never been told in a single place. Right side sleeping reduces left ventricular filling efficiency during the overnight blood pressure dip, creating reduced cerebral perfusion during the hours of greatest vulnerability. Pillow height and head angle place sustained mechanical pressure on the carotid and vertebral arteries in ways that no standard examination is designed to detect. Blood viscosity and platelet aggregation peak simultaneously between 3 a.m. and 6 a.m., creating a concentrated clotting window that sleep position either opens or compresses the most exposed vessels through. Undiagnosed sleep apnea adds repeated sympathetic surges and oxygen desaturation events directly into that same window, and lateral sleeping measurably reduces both. And supine positioning compresses the inferior vena cava throughout the night, reducing the venous return that sustains cardiac output and cerebral perfusion during the hours when both are already at their lowest. If you watched this video in a sleep position you have held for years and you are now reconsidering it, share that in the comments below. Tell me what position you were using before this conversation, and tell me what you are planning to change tonight. The patterns that emerge from what viewers share there are genuinely shaping what I research and cover next, and your experience is part of that. There is a specific person this video should reach tonight. Not everyone. One person. Someone who sleeps alone in a house where no one will be awake during those final 90 minutes before morning. Someone for whom the first sign that something went wrong overnight would be silence at a time when there should be a sound. If that person is in your life, sending them this video is not a casual recommendation. It is a quiet act of care that may matter more than you will ever be told. The next video in this series covers the morning routine that protects the heart during the first 90 seconds after waking. The window that cardiovascular research consistently identifies as the daily peak of stroke and cardiac event risk, when the blood pressure surges, the sympathetic system activates, and the specific sequence of movements made before full consciousness either spikes or steadies the system from the first moment. Subscribe so that video reaches you. You arrived here not knowing that the direction you faced on the mattress had a measurable relationship to what your cardiovascular system was doing in the dark. You are leaving knowing something specific about your own heart that most people will spend their entire lives never being told. What you do tonight with that knowledge is yours entirely. And here is the honest answer to the question planted at the start of this conversation: whether one night of correct positioning actually makes a difference. Research suggests that consistent left-side sleeping over time may support measurable improvement in overnight blood pressure regulation, venous return efficiency, and reduction in positional apnea event frequency. It is not a guarantee. The research does not frame it as one. But it is a change that costs nothing, that requires nothing new, and that your cardiovascular system, according to the cardiovascular sleep medicine literature, is biologically positioned to respond to, beginning tonight.